Good afternoon. Welcome to Medical Grand Rounds. We have a small but mighty crowd here, and I think 50 or so people watching on Zoom. More coming. We've been moving around from in-person and hybrid to Zoom only. Next week will be Zoom only. It'll be a COVID Grand Rounds, and our special guest will be Ashish Jha, who's now the national coordinator for all things COVID and former chief resident here. Look forward to talking to Ashish. This week we have a wonderful session talking about immune checkpoint inhibitors, the good, the bad, and the emerging field of cardio-oncology. Strikes me as an area that is actually fairly typical in medicine, where there's no free lunch. We come up with medications that are really revolutionary in their ability to treat certain tumors, but with it a new set of challenges and side effects that many of us have never seen before. And we're lucky enough at UCSF to have some national leaders in the clinical aspects of managing these complications, and also in research around what's going on and how best to prevent or treat them. So that will be our topic today. We have two speakers. The first will be Katy Tsai, who's assistant professor of medicine in our Division of Hematology Oncology. She's a medical oncologist and researcher who focuses on advanced melanoma and other non-melanoma skin cancers. She received her medical degree from Brown, did a residency at UNC and a fellowship in Med-Onc here at UCSF, and has joined our faculty in the Melanoma and Skin Cancer Program, where she is an active clinician as well as an active clinical researcher, and this is one of her key interests in managing adverse events from immune-mediated therapies. Our other speaker is Javid Moslehi, who is associate professor of medicine, also the William Grossman Distinguished Professor of Cardiology, and director of our new Cardio-Oncology program. Javid is a cardiologist who specializes in the cardiovascular health of cancer patients, cancer survivors, and patients with immunologic or metabolic problems that influence cardiovascular health, and is leading our cardio-oncology and immunology section. He is a nationally and internationally known researcher in these areas. He was a resident at Hopkins, did a fellowship in cardiology at the Brigham, and a research fellowship in oncology there, and then worked at Dana-Farber and at Vanderbilt, where he built this really wonderful career in cardio-oncology. We were really thrilled to recruit him to UCSF a year-ish ago. The time is sort of hard to remember in COVID times, but I think about a year ago, and has already made a tremendous impact here. So with that, we have a tag team, and I think Katy's going to go first.
Thank you so much for the kind introduction, and it's great to see everyone. I will admit that this is my first live in-person talk since pandemic years, so it's great to see all of you with or without masks on. So I wanted to talk with you today about immunotherapy, specifically immune checkpoint inhibitors, and both, as Dr. Wachter alluded to, both the good and the bad. So while I'm well aware that the history of immunotherapy in the treatment of cancer goes back a long, long time, probably before I was born, and we're standing on the shoulders of giants for sure. But I think for me, I wanted to start in 2010, so just about 10 years ago, so that I can show you really how rapidly the field has changed, even within the span of the early years of my own career. So the year is 2010. This is me as the lowly medicine intern on general medicine service at UNC, and that's our therapy dog, which I took lots of advantage of during those first couple of years. So at that point, I believe I was in the later year, so I would like to think that I was pretty experienced and efficient by that point. And I was admitting a young man with severe, severe diarrhea. So more than 10 bowel movements a day of just, watery stool. And in short order, we got him set up with IV hydration, started an infectious workup, got cultures before starting him on presumptive antibiotics. So patted myself on the back for that and was feeling pretty proud of myself. As the day unfolded, however, it came to light that he was on a clinical trial for his diagnosis of metastatic melanoma with a drug that had no name yet, but was a jumble of letters and numbers, MDX-010. The oncology attending who was on service at the time made a personal visit to see me and insisted that in addition to a number of things written down here, that I start the patient on a very high dose of IV steroids. I recall at the time thinking that I maybe didn't want to do that, especially in someone who was coming in with a rip-roaring infection. But I came to my senses, gave the patient a high dose of IV steroids, and really remarkably, the patient made a dramatic improvement within 24 hours and continued to improve for the remainder of his hospital stay. So dramatic improvement with an intervention that I certainly was not expecting and did not know much about. And that was really what sparked the interest. So as with many things in medicine, I feel like things that you don't know become a catalyst to learn more. And I think that this incident, which I remember pretty clearly, really had served two main purposes. So one is that it was a great introduction for me to the field of oncology, specifically medical oncology specializing in the treatment of advanced skin cancers. I was at UNC in North Carolina at the time, and Dr. Colicchio, who is my mentor at the time, and in many ways continues to be, together we saw many young patients who had no good treatment options aside from cytotoxic chemotherapy or non-specific immunotherapy, such as cytokine-based treatments, and the median overall survival was really quite poor, as you can see here. The second introduction was to the world of immunotherapy, specifically immune checkpoint inhibitors, so named because they block an inhibitory signal responsible in T cell activation and proliferation, such that the brakes on your proverbial soldiers of the immune system are released and can affect anti-tumor immunity. MDX-010, later christened ipilimumab, as you can see here, is an antibody that targets the immune checkpoint CTLA-4. And this was the first immune checkpoint inhibitor approved by the FDA for the treatment of metastatic melanoma. A couple of years later, we discovered another immune checkpoint, the PD-1 axis, and there were, in short order afterwards, two anti-PD-1 drugs, pembrolizumab and nivolumab, approved by the FDA, again, for the treatment of unresectable and advanced melanoma. Now, I always like to make the point to my patients and also to my colleagues that even though immunotherapies are given intravenously, so in many ways they look and smell like chemo, and a lot of people get pretty nervous that, oh no, am I going to get nausea? Is my hair going to fall out? They're really quite different with very different mechanisms of action. And I can go into that a little bit more in detail here. So taking the 10,000-foot view, talking about immune checkpoint inhibition, the two standbys in our field are, as I mentioned earlier, the anti-CTLA-4 and the anti-PD-1 or PD-L1 antibodies. If you look at the top row, certainly they play similar functions in inhibiting regulatory T cell signals. However, I like to describe the anti-CTLA-4 drugs as acting more proximally, so at the level of the lymph node, where in the lymph node, a binding of CTLA-4 to its natural ligand causes a T cell inactivation. In other words, there is an absence of a co-stimulatory signal, and the T cell remains quiescent. However, if you look over here, let's see if I can get the mouse moving. Maybe not. But if you look at kind of the left-handed corner of the right-handed, oh, there we go. So if you look over here, so if you block CTLA-4 such that a co-stimulatory signal can occur, then the T cell becomes active and educated against cancer antigen and can then migrate to the tumor site. So when this active effector T cell then migrates to the tumor site, sometimes there is still the opportunity for it to be inactivated if PD-1 interacts with its natural ligand, PD-L1 or PD-ligand 1. So if that happens, again, you have the problem of an inactive T cell that is not affecting any anti-tumor activity. However, if you then deploy either, if you block either end of this axis, so either an anti-PD-1 antibody or an anti-PD-L1 antibody, then again, you're allowing a co-stimulatory signal to take place, which is then able to invigorate or reinvigorate the effector T cell to affect tumor cell killing. So again, both do roughly the same thing, but we think at different levels of immune cell education and cell kill. So back to 2010. So I finished my intern year, and then the very next year in 2011 is when ipilimumab gets approved. And you can see that, how rapid this is, because by the end of my 3 years of residency, we are seeing a dismal prognosis, overall survival in metastatic melanoma of less than a year, to something a little less dismal. So still plenty of room to go. But at a year, we finally have almost 50% of patients still alive and well. So then I come to UCSF for fellowship, and as I mentioned earlier, this is when the anti-PD-1 antibodies get approved by the FDA. So we're seeing approval of Pembro, Nivo during fellowship. Then a combination therapy, so a more aggressive regimen of ipilimumab plus nivolumab gets approved. And again, we're seeing advances in overall survival here. Then I hit my faculty years, and even though it seems like there really isn't that much going on between the years of 2016 to present day, this is a little misleading. So even though there were no new immune checkpoint inhibitors or no new classes of immune checkpoint inhibitors approved, I should say, there's plenty of activity going on in melanoma. So the drugs that we were using in the unresectable and metastatic setting are now being deployed earlier and earlier in the disease stage. So this is now not only limited to sick stage 4 patients, but it's being deployed as adjuvant therapy for stage 3 and 4 patients, meaning drug therapy given after surgery to remove all visible tumor to try and prevent any recurrence of the melanoma. I will point out that actually this is pretty groundbreaking for our field, that just last year, that adjuvant PD-1 antibody pembrolizumab was approved for stage 2 melanoma. So the difference between stage 2 and 3 is that in stage 2 melanoma, actually, we're not even seeing any regional involvement of the lymph nodes. So again, moving earlier and earlier up in the disease presentation. Really briefly, I'll also mention that this is now being used in a neoadjuvant setting. So again, earlier, these are patients who perhaps have very limited regional disease, and in neoadjuvant therapy is drug therapy given before surgery to try and shrink down the tumor, make things a little bit easier for our surgical colleagues. So all of that is happening within the past 5 years. And to cap it all off, just earlier this year, there is a new class of immune checkpoint inhibitor approved. It's called relatlimab and is approved to be given together with PD-1 antibody nivolumab. And this is just a quick slide to mention that relatlimab is an anti-LAG3. So this is targeting an immunoregulatory pathway that inhibits T cell activity, much like PD-1. But because these are distinct cell receptors and distinct pathways that contribute to tumor-mediated T cell exhaustion, there was recently a big phase 3 study reported out that showed activity in melanoma, and hey presto, now we have 3 distinct immune checkpoint inhibitors approved in our field. So maybe widening the view out from just me, I wanted to show you, in a broader sense, the progress that's been made in metastatic melanoma. So these are overall survival curves. And just to orient you a little bit, so on the x-axis here, you can see, time 0, and then moving along to the right is advancing time in months. On the y-axis, we have overall survival. In other words, a percentage of people in this given sample who have not yet experienced the outcome of interest, which in this case is death. So if we look at the chemotherapy overall survival curve, you can see that Here at time 0, we have 100% of people still surviving, but that over time we have attrition. And if we look at the median overall survival, so it seems like right around at 6 months is when we have half of people or half of these patients no longer here, even if they were treated with chemotherapy. So here the median overall survival is 6 months, certainly could do a lot better. Moving forward, looking at cytokine-based therapies, just from a distance, you can see that the median overall survival is improved. It's closer to 1 year here, but certainly still a lot of attrition, although one positive perhaps with even this non-specific immunotherapy is that you're seeing what we call a tail on the curve, right? In other words, so the cytokine-based therapy may not work for everyone, but we are still seeing activity. And then moving on forwards, and this really kind of blows my mind that this has happened during my career, we move on to immune checkpoint inhibitors. I mentioned the approval of the more aggressive active regimen of combination ipilimumab plus nivolumab, which is indicated here in red. So median overall survival here, I know the text is small, but we're up to more than 70 months, 70 months. Median overall survival for patients with widely metastatic melanoma. So certainly something to celebrate, and I hope illustrative of how this has transformed cancer care in general. So why should you all care? I mean, this is great for melanoma patients, but how can we start to generalize this to our field in a broader sense? So this is a slide that is busy by design. This is a slide from the Cancer Research Institute showing in all these colorful dots different checkpoint inhibitors that are now approved. And on the upper, on the x-axis here is a long list of cancer types in which this is now approved. So this is relevant not only for melanoma, but all types of cancer, gastric cancer, colorectal cancer, genitourinary cancers. And in what was a groundbreaking FDA designation, is actually approved also for a disease agnostic indication. So for types of cancers that are able to show a lot of DNA damage pathway activity, any cancer demonstrating that is eligible to receive an immune checkpoint inhibitor. So this becomes incredibly relevant not only for patients who are actively receiving immunotherapy, but those in the post-immunotherapy setting. So along with these big increases in survival for our patients, we are seeing increasing survivorship. And actually from about 2020 to 2030, we're going to see in the US an increase in numbers of 30%, from about 17 million cancer survivors to 22 million cancer survivors. And certainly here at UCSF, here is a bar graph over time showing both accounted for adult immunotherapy patients at UCSF and also projecting out into fiscal years 22 and 23. So really the net here is that you will see patients who are on active immunotherapy or who have a history of immunotherapy treatment. And from that standpoint, I think it's really important to recognize some special side effects that we see with this class of therapy. The question actually becomes not necessarily what organs do they affect, but unfortunately, what organs do they not affect? You can see here from this cartoon that really any organ system can be hit. Some organ systems are more commonly hit than others. For example, the gastrointestinal, skin, and endocrine organs are pretty commonly described. But really, we can see rare inflammatory events as well involving the eyes, the kidneys, neurologic presentations, you name it. So, a decade plus now after ipilimumab approval, what do we now understand? So I think the first thing I would say is that immune-related adverse events, or IRAEs, affect a broad range of organs and therefore require a tailored management approach that is organ system appropriate. And they vary not only in presentation and severity, but also I think in underlying biology. When we think about time to onset, so I think commonly with oncology drugs, the tendency is to think, okay, you give someone a drug and then in short order, maybe in days or in weeks, they develop a side effect. So immunotherapy really kind of takes that paradigm to task. So here are some charts of, again, x-axis here moving forward is time in weeks. And then severity of the toxicity here is indicated on the y-axis. You can see here that most side effects tend to happen within 3 months of immunotherapy start. However, we are, anecdotally and also published in the literature, we know that these side effects can happen as late as a year or more on immunotherapy, and sometimes even after, long after immunotherapy has been discontinued. And so I think here's just a graphical recognition that these inflammatory side effects can be seen with both CTLA-4 blockade and with PD-1 blockade. So not only can these IRAEs happen at any time, but I think it's important to recognize that they also don't all resolve. Right? And this is really important when we counsel our patients and also when talking to our colleagues that, yes, these side effects do happen, and some of them can be permanent. And in some cases, they may require lifelong therapy with either hormonal supplementation or even with other forms of immunosuppression. And the organs that we most commonly tend to see become chronic or permanent involve endocrinopathies, skin inflammatory issues such as rash or pruritus, and also the gastrointestinal system, usually consisting of some sort of inflammation of the bowels, which could manifest as intermittent waxing and waning diarrhea or abdominal pain, or even upper GI presentations like bloating, nausea, and vomiting. I think the third point that I'll make here is that really despite heterogeneity in known presentation and underlying disease biology, that the mainstay of treatment revolves around glucocorticoid treatments, usually several weeks worth. In terms of general guidelines for treatment, this is codified. So we have a rubric by which we can try to objectively describe the severity of an IRAE. You can see here that the scale is from grade 1 to 5, 1 meaning mild and 5 meaning death. And in between, you have a spectrum. And you can see here that this is a tabulated slide of recommendations from professional societies. And if you look up professional society recommendations, these are really well described. And my goal today is not really to dive deep into how to manage these particularly, but really to try and raise some interesting questions that are relevant open debates in our field right now, and to give you some sense of the future and where I think things could head. So in terms of innovation in the management of IRAEs, I think some relevant questions right now are, for which IRAEs and for which patients do we actually need to deploy high-dose prolonged steroids, over 4 to 6 weeks? Is that really the best thing to do, and how much does that interfere with their tumor response? In that same vein, what immunosuppressive strategy is best for patients who have steroid refractory IRAEs? Very often the immunosuppression that gets used, because this is very medicine subspecialty expertise dependent, often the immunosuppressive strategy that's deployed makes sense for that particular organ system. And I think this really highlights the role to date of expert opinion in the management of these side effects, and the value of retrospective data to help guide us. I think that in the future, we really need to start looking at prospective trials to help us guide, best practices in IRAE management. And that's already beginning to happen now, 10 years after IPI approval. So how can we do better? And I think I wanted just to really briefly run through that paradigm in 3 different settings. I wanted to explore this in both the acute setting, the chronic setting, and in the unknown setting, of which there are plenty of examples these days. So I've already mentioned colitis, which we know is pretty common with immune checkpoint inhibition, especially when we use combination immunotherapy. And I think that my main point here really is that this type of acute life-threatening, potentially life-threatening side effect is not necessarily something that you want to sit around on, right? You need to abrogate this inflammatory response and do it quite quickly before someone ends up, like the patient at the beginning of this talk, in the hospital with dehydration and feeling very ill. So here, to my earlier point, we are seeing that there are clinical trials now trying to explore the best immunosuppressive strategy, right? Do we employ a TNF alpha inhibitor like infliximab, or maybe consider something more specific from the GI world like vedolizumab? Which one works best up front? Do we give it with steroids, without steroids? What dose of steroid is best in conjunction? So these are all pretty open questions still in our field. And even though the prevailing mindset may be a little bit of act first with steroids and think later to try and keep the patient safe, I think it's really interesting to think about, how can we do a better job of risk prediction, right? Are there certain things about the patients, or either their disease-specific factors or their host factors that could help us be better able to prognosticate and estimate, first of all, whether or not they will develop an IRAE, and second of all, which IRAE that will be and how severe it will be. So here is a slide just to highlight some work from my colleagues, Dr. David O and Dr. Michael Kata in HEMONC and GI respectively. And they have done some work looking at or trying to look at predictive biomarkers and immune mechanisms for immunotherapy-related colitis. They've been able to take a paired blood, peripheral blood and biopsy specimens from immunotherapy colitis patients and compare them to healthy controls, and also a population of patients with inflammatory bowel disease. I know this is a busy slide, but really here I just is a snapshot of their workflow. Again, looking at peripheral blood and tissue biopsies. And also you can see here that I think the punchline here is that looking at patients who in the control population and in the checkpoint inhibitor population, that there were certain types of effector T cells and also resident memory T cells that were enriched in the checkpoint inhibitor colitis population that were not seen in the control population. So I think taking that forward, there's probably a lot of interesting work that could be done from a prognostication and diagnosis standpoint. As a contrast, we also have now emerging in the research literature a more chronic presentation of IRAEs, and I think this is especially relevant if we think about the survivorship population. Inflammatory arthritis, I think, as a counterpoint to colitis. This is a population where we may have the luxury of not deploying steroids right away, but then the interesting questions become, is it dangerous to withhold high-dose steroid, right? If we can get away with maybe a more conservative management, but I think more research is definitely needed to see what impact this has on cancer treatment outcomes. Is this harming them in any way? Does this increase their risk of progression of said chronic inflammatory disorder to something that's longer lasting and smoldering? I think in the interest of time, I will mention here just that there is plenty that is unknown. I mentioned earlier this chronic IRAE survivorship population, and I think now that we have Dr. Moslehi here at UCSF, there's certainly a lot we can explore as far as the impact of chronic smoldering inflammation on other processes that we know can be influenced by chronic inflammation, such as atherosclerosis. There is now preclinical data and clinical data to show that perhaps people who have received checkpoint inhibition are at higher risk of accelerated atherosclerosis. I have done some work here with Dr. Nelson Schiller's lab to identify a cohort of patients receiving immunotherapy and do some pretty detailed resting and stress echocardiographic analysis with them. And I think taking this forward, that certainly we could think about correlating this with atherosclerosis seen on their regular follow-up imaging to see if there is a correlation with that in our population. So last but not least, I wanted to highlight really, I think, my vision for IRAEs at UCSF. The challenge in the care of these patients, which I've hopefully been able to demonstrate to you in the last couple of slides, is that it really takes a village. I, as a medical oncologist, may have certainly learned a lot about how to manage these chronic and acute IRAEs, but there is such a wealth of information at UCSF, within each medicine subspecialty that I think it can only be much improved care for the patient and for our research endeavors if we come together to put our heads together and really try and offer the best that we can for this patient population. So to that effect, what we're envisioning here at UCSF is the CITE program, Cancer Immunotherapy Toxicity Evaluation Clinic, which will be NP run. We're currently hiring. So if you know anyone or can recommend anyone, that would be great for us to work with. It will be co-directed by myself and Dr. O. And I think the workflow really is that the patients would be triaged by a nurse practitioner. We would be able to take these cases to a multidisciplinary board, if you will, almost like a tumor board, but involving multiple medicine subspecialties, and be able to improve our clinical care as well as drive and build a research enterprise here at UCSF for mutual benefit. So with that, I will end. A lot of people took knowledge on this slide. This certainly could be a 2-hour-long talk, but to spare all of you, I will now stop and hand it over to Dr. Moslehi to continue the conversation about cardio-oncology and cardiac IRAEs. Thank you.
It's actually here, but I brought it up here in case. Here we go. Ooh, how do I get this up here now? There you go. Thanks again, Katie. I've only been here about 6 months so far, and it's been a real pleasure to work with many of you. I've gotten to know some of you, and I see many people, even here in the audience, that I knew from my former institutions. So I'm a cardiologist, and I've been interested in this intersection between cancer and heart disease for the last several years. This is obviously translates into clinical things that I'll talk to you momentarily, but also some research questions that pop up. And I'm going to use the example of checkpoint inhibitors and checkpoint inhibitor cardiovascular issues, namely myocarditis, as an example of how one can interrogate this. I do have a couple of financial disclosures, the most relevant of which is in the bottom. I'm going to talk about new possible treatments for myocarditis checkpoint. And we have a patent. This is a patent that's shared between Vanderbilt and Sorbonne University. And that's sort of my most relevant financial disclosure. So you may ask, what is cardio-oncology? I had the pleasure of working on this with Alan Beck, who's sitting in the audience, and Mandar Aras. And this is a picture from a few years ago, kind of depicting where cardiology and oncology intersect. So we certainly have cases where the cancer itself can cause cardiovascular disease. And here at UCSF, Emily Berksland has really set out an outstanding program looking at neuroendocrine tumors. And with Mandar Aras, they're looking at how these neuroendocrine tumors can cause specific valvular disease, namely carcinoid heart disease in patients. Here also at UCSF, there's Sandy Wong, who's worked closely with Mandar Aras, creating an amyloid program. Again, why does plasma cell dyscrasias cause cardiac disease? And that's fundamentally an important question. One thing that's been interesting and which has really expanded this intersection has been this growing appreciation over the last few years that common risk factors predispose to both cancer and heart disease. We all know about smoking, and if you smoke, how you may have lung cancer and heart disease. But really, over the last few years, we've had some unexpected findings that maybe diabetes and high cholesterol or obesity, classic cardiac risk factors, are also important cancer risk factors. And this has really come about very interestingly in the form of somatic gene mutations, this condition called clonal hematopoiesis of indeterminate potential, or CHIP, where epigenetic mutations in blood cells which our oncology colleagues have known for many years can cause hematological malignancies, probably become the most significant cardiac risk factor and for patients to have heart attack. And so here with Tom Martin, we've been thinking about how to include and expand this into a clinical program. And of course, this has relevance for 18 million Americans. That's how many cancer survivors we have. That's 5% of the US population. And while many people know that our 4 million breast cancer survivors have a higher risk of developing breast cancer later, for them and many other cancer survivors, cardiac disease is number one risk. And so one of the questions we ask is, how can we prevent these cardiac events from happening? And if you think about this for a minute, this fact that these common risk factors may predispose to both conditions, that gives us an opportunity to really intervene. And I would argue this has significant public health implications. And finally, I think it's important to also note that the cardio-oncology field has really come about. In fact, many of these issues, including the survivors, has been how well our oncology colleagues have done, bringing in new therapies that have really redefined what we think about cancer and mortality. In fact, many cancer patients now are survivors, and that's because of new therapies. And many of these therapies are targeted, and so that many of them also has cardiovascular issues, and that's been one of the areas where we have expanded clinically, where many therapies sometimes unexpectedly can cause cardiovascular issues. Now, this is a picture I wrote for a journal a few years ago, in fact, a little more than 5 years ago. But what was unexpected and what I didn't capture in this review paper was what we saw later, which is patients who showed up with immune checkpoint inhibitor myocarditis. So Katy went over this very nicely, what these immune checkpoint inhibitors are. Many of them are used in combination. For example, you give ipilimumab, an anti-CTLA-4, and nivolumab, a PD-1 inhibitor. And this was a 65-year-old female who showed up to the ER at Vanderbilt with bradycardia and heart block. And what turned out was fulminant myocarditis. Unfortunately, this patient passed very quickly. Effectively, what we were looking at was a new clinical condition that had really never been described, the myocarditis that can occur with these checkpoint inhibitors. So we have been now working on trying to understand better what this admittedly infrequent toxicity is and what kind of biology we can learn from this. So at this point, we did something completely outside the box, using a web-based platform to collect cases from around the world. And this now we have about 600 cases from around the world. Many of them come from Europe and France and the US. And literally now this includes about 600 patients. And I should say we have a lot of good collaborators and contributors to this, but some of the heavy lifting for this actually happened with house staff at Vanderbilt. And they're pictured here. They did some of the very heavy lifting of making sure the data are de-identified, data are collected in some ways, and some of them have gone on to be fellows now and start academic careers. So what have we learned? So we know that there are different cardiovascular issues that can arise. By far, myocarditis is probably the most common and certainly the most fatal. And we've learned a lot about what checkpoint inhibitor myocarditis is. It's classic myocarditis in that T cells and macrophages infiltrate the myocardium. When you have myocarditis or any other cardiac issues, you can have the electrical system of the heart die or the pump of the heart die. And classically, we think of myocarditis as heart failure, classic heart failure. For some reason, that's not the case here. Many of the patients present with sudden arrhythmia and sudden cardiac electrical abnormalities, which we think is very fascinating. This is not your usual myocarditis. We recognize that many patients, including that patient I showed you in the earlier slide, present with myocarditis, but they have a couple of other IRAEs that we see. One is myositis. The other, for some reason, they get myasthenia gravis or a myasthenia gravis-like syndrome. In fact, if they get that, we know that's a very severe for the patient. We have been looking for a lot of risk factors. What are the risk factors? Who gets this? Are the patients with heart failure before who had heart attacks? Are these patients with lupus? And we have not found much in that realm. One thing that we go back to again and again is that these patients have, when you combine therapies, and that's clearly the name of the game, when you combine this anti-CTLA-4 and PD-1, the incidence is low. That's the good news. That's 1% only get myocarditis when you combine these therapies, although the mortality, even to this day with 600 patients, is about 40%. So we have delved into the biology of this and created a number of mouse models that we can then use to potentially test and think about the underlying mechanisms and think about diagnostic and treatment strategies. One of the reasons I like this field of cardio-oncology, because as a scientist, the drugs are very targeted. So you can imagine there's something about CTLA-4 and PD-1 signaling that leads to issues that arise in the heart in terms of the heart and the immune system intersect. And so we've developed a number of different models, pharmacological models, but in a very nice collaboration with Spencer Way, who's now actually in California and San Francisco, and Jim Allison at MD Anderson, we've created mice where we have genetically knocked out CTLA-4 and PD-1. And only when you cross these mice together, the mice die shortly after weaning them, after you separate them from mom and pups. And they die very suddenly, which was very striking to us. One thing I should mention is many other people have made single CTLA-4 knockouts. Those mice die of significant autoimmunity that affects every organ. And many other people have made PD-1 knockout mice, and nothing really happens to those mice. But only when you cross them, we surprisingly found these mice die. And for some reason, the female mice are preferentially affected, which is very interesting to us. And that when you think about general myocarditis, that's especially interesting. Now, if I told you these mice died of significant autoimmunity, that would not be very interesting. But these mice die of one reason and one reason only, and that's due to myocarditis. We have done a lot of experiments to convince us this model recapitulates what we see in patients. They have electrical activities that's seen on the top here. And then we've gone on to further identify and use single-cell RNA-seq and TCR sequencing to characterize what these immune cells are. These are sorted CD45 positive immune cells from affected mice and controls. And as you can see on these UMAP plots, that's what we use as to identify specific cells and how they track with the genetics. You can see that there's expansion of T cell clusters, specifically activated T cells and macrophages. And that to us is very interesting. And if you just look at the T cell clusters, that's in the bottom here, you can see that activating molecules are upregulated in the myocarditis mice, whereas naive markers are activated in the normal controls. So these are, for all intents and purposes, activated T cells that we see in the mice. Given this high infiltration of T cells, we've next sought to assess the clonality of the T cells. Our T cells are very, very varied and broad. That's how we can fight infection 1 versus infection 2. And but they're basically defined by these receptors, alpha and beta receptors on the T cells. And you can look at clonality. And what you can appreciate here is you can see significant clonality in the myocarditis affected mice. In fact, 63% of the clones are clonal. We see none of this happening in the control mice. And these control activated T cells overlap with activated T cells overlap with these expanded cells, suggesting these T cells are probably doing something. This is very interesting because, as I mentioned, when we see patients with myocarditis, and this is now patient data, these patients often have myocarditis and myositis. And when you look at the T cell populations, what these T cell clones are, when you look at the heart tissue and compare this to the skeletal muscle, one thing that's very interesting is that there's a lot of overlapping T cells in the skeletal muscle and the heart. And that's probably not very surprising for people because these two they're both muscle cells and they probably have similar antigens. So they find the same clone of T cells in the two tissues. But when you look at the tumor, and if I told you these tumors were melanoma tumors, we see the same clone of T cells in these tissue, and they overlap with what we see in the heart. And that to us is very interesting, because why would melanoma have anything in common with the cardiac tissue to see similar similar overlap with them? We have done a number of experiments to convince us these T cells, and in fact, these CD8 positive cells, are necessary for the development of myocarditis. We've crossed these mice with T cell deficient mice, but I think the most telling experiment is this adoptive T cell experiment, where you take immune cells, splenocytes, from this affected mice, transfer them to other naive mice, specifically immunodeficient mice. And then before we do that, we deplete them with using an anti-CD8, testing specifically the hypothesis of whether T cells, and specifically CD8 positive T cells, are necessary for the development of myocarditis. And as you can see here, that is the case. These T cells are absolutely necessary for the development of myocarditis. And I think this experiment is also telling, because as you can see here, when we then take those T cells and see what population of T cells we have, we see the clonality of the T cells. In fact, 65% of T cells we find in these mice tissue are one single clone, and many times between different mice they share similar clones of T cells. We've gone on to do some experiments. This is done in collaboration with Justin Balco and Maggie Axelrod, who's a terrific MD PhD student at Vanderbilt, to look for potential antigens that drive this shift. And for those of you who have been following this literature, there's a lot of biology that's being uncovered in terms of, and a lot of methodology to determine how we get antigens. This is the holy grail of all of oncology. What are the antigens that drive our T cells? And so you can do a number of different experiments, but here what we have done is take published sequencing data from thymic APCs, and we show that 4 specific cardiac enriched genes are actually not expressed in the thymus, meaning we probably don't delete them when we select for these T cells during the T cell maturation. And we've gone on to use a number of different technologies, namely reconstructing these T cells using a method used that recently published by James Heather at Mass General, cloned and transfect these into a reporter cell system, where you can see in this case, we think the alpha myosin heavy chain may be the driver and the antigen driving this. And so again, some of you may say, well, this is all great. You're doing all this mouse stuff. There's a lot of interesting biology, but does this really help our patients? Well, we think it does, because I think having a model that recapitulates the system, that you show that maybe has relevance and overlap with what we see in our patient population, can provide a platform where you can test new diagnostic and therapeutic approaches for our patients. And so in this setting, I told you that the main risk factor for myocarditis is, for some reason, when you combine CTLA-4, anti-CTLA-4 and anti-PD-1. Data I did not have time to show you, we show that the genes for CTLA-4 and PD-1 functionally interact in a gene dosage dependent manner. Again, I did not have time to show you that the CTLA-4 signaling is critical for this process, and we think we've uncovered an unappreciated role for CTLA-4 signaling in the heart. And that leads one to think about a hypothesis. Can we reverse the CTLA-4 inhibition, possibly by giving CTLA-4 back as a treatment strategy for myocarditis? Well, you can do this a number of different ways. You can introduce the gene back, but fortunately, there's a drug named abatacept used by rheumatology colleagues, which binds the CD8086, which is the target of CTLA-4, and in an indirect way, it activates CTLA-4. And when we test these against our pharmacological models, you see attenuation of inflammation, but more strikingly in the genetic model, which is more significant, this can reverse the myocarditis. Again, you may ask, well, does it have any relevance to our patients? One of the things I did at Vanderbilt is we started a cardio-oncology program, in fact, a cardio-oncology fellowship. And this is Joe Ali Salam, one of my first fellows. He had just finished doing these experiments to lab. He went back back to Paris and has set up what's arguably the best program in Europe. And he treated the patient. This is a case report he had in the New England Journal of Medicine a few years ago, where abatacept reverses this. And we've now treated about 50 patients across the globe that have benefited from this, including a patient here that now Mandar Aras is seeing in our clinic. I wanted to give you a couple of parting thoughts. One thing is we've worked a lot as a cardiologist to develop systems, both mice and human samples. And one thing you can do is kind of hoard onto these things, keep it for yourself. We've done exactly the opposite. We've shared this with anybody and anybody who's interested. In collaboration with Doug Johnson and Justin Balco, we just received 2 R01s to determine what these immune and antigenic populations are. In collaboration with Yang Huio Seo, who happens to be a radiologist here at UCSF, we're looking at using these mice to determine better diagnostic strategies for myocarditis. And anybody who's taking care of myocarditis patients knows it's a tough diagnosis, right? It's a diagnosis of exclusion. In collaboration with Chunru Lin and Liu King Yang, and this is Zhuan Qin, whose picture I showed you in the lab. She has a nice science translational medicine paper coming out in the next few weeks, showing what this sex discrepancy is. This is important for this form of myocarditis, but I would argue it's also important for other forms of myocarditis. And so I'll let her explain to that sometime later. Corey Levine at WashU has been a close collaborator with looking at the macrophage population. And finally, Chris Sorosiak and Tony Latai in Boston were looking at what the immunogenic cause of myocyte death is, something that's never really been explored previously. I want to leave you with 2 parting thoughts. One is my sort of where I sit as a cardiologist and what we know about myocarditis. Sadly, and I'm a cardiologist saying this, and a supposed myocarditis expert, we do the same thing we do for myocarditis that we did 30 years ago. We take tissue, look at it under a microscope, and depending on how much coffee your pathologist had that morning, they may or may not see a giant cell that exists there. And that seems really, really tough to me as to diagnosing and thinking about myocarditis. But we have a lot of new technologies, many of these developed here at UCSF. And one of the hopes of this new section of cardio-oncology and immunology is how can we decipher, how can we look at this cardiac immune interaction? Now, I would argue this goes beyond myocarditis with cases like transplant rejection, hypertension, atherosclerosis. And if you apply these technologies, we could really be helping our patients, and not just for the cancer-treated patients. The other kind of thought I wanted to leave you, and Katy touched on this, is I'm just a cardiologist. But if you think about it, there are a lot of issues that come about from patients that affect every other organ. And you can think about this as a new possibility, new clinical operation. But I would argue if we study these patients, they teach us a lot about autoimmunity in general. And I've had the pleasure here to work with Michael Kata here in GI, Zoe Count in pulmonary, and Anthony Shum, who's actually my next door neighbor at CVRI, who's a pulmonologist, trying to think about how we think about these issues. And I would argue these are important questions, just both for our patients, but I would argue they offer us insights into autoimmunity. The last parting thought is I think this is a great platform for physician scientists. You can actually do pretty well seeing specific group of patients, and these offer us questions about how we can delve into the lab and study this. And I'll stop here. This is our group, and I'm thankful to a number of people, including my boss, Jeff Olgan, who approached me about coming to UCSF. Great to be here.
Thank you both. That was fabulous, and actually good reason to have a Department of Medicine. It feels like this is uniquely collaborative across the department, and obviously with some other departments thrown in, including dermatology and neurology. Let me start out with a question or two. Maybe Katy, why don't you come on up? I can grab a mic. It works. There we go. Why would this work better on certain tumors than others?
I'm so glad you asked that because I feel like melanoma is often held up as kind of the poster child or where immunotherapy started. So it's complicated is the short answer. But I think, things that have been brought up in the past that do hold some water, although I think it's not quite as black and white as that, are, for example, Javid was talking about antigens, right? Your immune system needs to be able to see and recognize an antigen in order to attack it. So from that standpoint, tumor mutational burden, for example, that's something that's been talked about, and there is evidence for high or tumor types with high mutation burden to respond more robustly to immune checkpoint inhibition than those with lower TMB.
Okay. And for either of you, why would the treatments of the adverse effects not cause the cancers to proliferate, assuming there are still a few cancer cells hanging around? Yeah, I don't know. You want to start with that, Katie, and then Javid can add something?
Sure, two perspectives. Yeah, I am so glad what you said earlier, Javid, about, I didn't get a chance to go into this, but, that first slide I put up, that algorithm for treating toxicity from ipilimumab that I carried out faithfully in 2010. There's not much difference between how we treated checkpoint inhibitor-associated colitis 10 years ago versus now. So I think we really need to leverage scientific and technological developments that have happened in the intervening 10 years to really get more granular about what's the pathophysiologic basis for this happening, and can we get at the root of the problem rather than just throwing steroids at something.
And is there any empiric evidence of what happens to tumor survival after aggressive treatment for one of the adverse effects?
Yes, so there are a number of retrospective studies looking at that. That also is complex. I will say that I think that there is data for high-dose steroids that does or can in some way abrogate the tumor-specific immune response. But it's not across the board, right? And I think, for example, looking at melanoma brain metastasis patients, those patients who are already on steroid, there is an example where there's definitely data that if you're a brain met patient and you are on steroids, systemic steroids, and you get treated with immune checkpoint inhibitor, you do more poorly. But it's complicated in the sense that, well, maybe that person being on, is it a confounder, right? Sure. Maybe you're just sicker and had a worse prognosis to begin with by the mere fact that you were on steroids. Yeah. So,
do you have anything you want to add?
Yeah, so that's been a pushback we have gotten on the abatacept, as you can imagine. And so we're experimentally addressing this using this other model I didn't show you, where we put the tumors in and then give abatacept, and at least the data that I didn't share with you, but there appears to be no effect. The other issue that comes up is from our 50-patient cohort now that we've treated. Some of these patients we've followed longitudinally. The issue with myocarditis is it occurs often early after initiation of treatment, but the decision as to whether you actually respond occurs 3 months later, long afterwards. And surprisingly, to us at least, we have seen no effect on the tumors. And even patients who receive 1 or 2 doses, there's this prolonged effect on the tumor that to me is very surprising. As I talk to my many oncology colleagues, they also bring up this idea of how many treatments do we really need? Is it just 2 treatments seem to do the trick? And obviously there is prolonged treatment in different patients depending on the type of tumor you have. But it could be that the effects are immediate and there is something, and I think we just need to understand the biology here a little bit better.
Okay. Any questions from here? I know we have 100 people watching, and I hope nothing. If anybody has questions, put them in the Q&A. Any questions from anybody here? Last one more. Blood-brain barrier. I know a fair number of these are neurological effects, and also blood-brain barrier for melanoma, given that the mets are often brain mets.
Yes, a super important question. And actually, now that we are improving survival for a lot of our metastatic melanoma patients, we are seeing that, among other sanctuary sites, the CNS is definitely one of those where we get people past treatment, then 4 years later, 5 years later, they show up with seizures and brain metastases. We've both talked about the relative value of a combination CTLA-4 plus PD-1 blockade. So the combination of ipilimumab plus nivolumab is approved and especially has shown great activity in the CNS. So if you treated 100 patients with melanoma brain metastases, chances are you'd see an objective response or a shrinkage in brain mets in about, probably 50% of those patients who get ipi-nivo. So there definitely is activity there. I think again, because the immunotherapy affects indirect tumor cell killing, I feel like I'm a little bit less worried per se about drug penetration through the blood-brain barrier rather than how active are the T cell clones that make it into the CNS.
Yeah.
So,
any final questions? One last one, Rebecca.
I just have a quick question. Actually, pairing these talks was very interesting because you mentioned in your talk that the PD-1 inhibitor, the PD-1 knockout mouse kind of grows up normally. And so is the PD-1 checkpoint inhibitor have fewer side effects than the other? And does that weigh in if you have someone who maybe doesn't have quite metastatic melanoma, but it's like stage 3, does that play into your decision making about which to start?
Mm-hmm. Yeah. In some ways, the order in which these got approved by the FDA is somewhat telling. So IPI was approved first. Better activity than the cytotoxic agents beforehand, but also quite toxic. And then when the PD-1 antibodies got approved, we know from phase 3 studies that the PD-1 antibodies have more efficacy and are less toxic, meaning there are fewer IRAEs and potentially less severe IRAEs than what we see with ipilimumab treatment. So that definitely factors into treatment decisions. That's why ipi-nivo, for example, is not approved in the adjuvant setting. And that's why, for example, ipi-nivo is not approved, at least yet, in the adjuvant setting, but more for the treatment of metastatic disease. Presumably there, the risk is, somewhat is outweighed by the potential benefit.
Okay, we'll give Javid the last word.
Yeah, I think this is really important, but to be frank, combination therapy is the name of the game for many other cancers. I mean, checkpoint inhibitors now are approved in kidney cancer or triple negative breast cancer. You're not going to withhold the many other therapies that patients get. So either it's combination with other checkpoint inhibitors, but I think in many other settings other than melanoma, there's really true combination with the other drugs that we use. And I think there is going to be added toxicity with these that we have to sort of think about and deal with. Doesn't mean we don't give the drug to the patients, just something that we have to address clinically.
Great. Well, first of all, thank you both for great talks and the work you're doing. And as we think about the toxicities, I can't sort of get past Katy's initial slide about the survival rates. These are really transformative treatments, and it's great to have you both here doing this work. Next week, again, we'll be virtual with Ashish Jha talking about COVID from his perspective as national coordinator of everything COVID right now. Thanks so much.